Good morning, good afternoon, or good evening, depending on where you're joining us from. This is the ISDE, or International Society for Diseases of the Esophagus Esophageal Cancer Virtual Tumor Board. What we're hoping to do here is to maintain the highlight on esophageal diseases during this pandemic or this period of time where we're all alone. We hope to continue this momentum into next year to our annual meeting, which again will be in the next year at the end of the summer, beginning of September in Toronto. Today we've really assembled a who's who of international experts in esophageal cancer. We're extremely excited to have a phenomenal panel of esophageal experts from really around the globe. I'm Lorenzo Ferri from McGill University in Montreal. My co-moderator is Mark van Brugge-Hennegoen from the Amsterdam University Medical Center in Holland. Going chronologically from morning to evening, we have Wayne Hofstetter joining us from MD Anderson Cancer Center. And we have John Reynolds from Trinity College Dublin in Ireland.
And then we have, of course, Simon Law from Hong Kong, Yuko Kitagawa from Japan, and Mark Smithers from Australia. We're really very, very proud to have you all here in this expert panel. So I think we can get our panelists in with their microphones off, but their cameras on. There we are, John, Simon, Mark, Yuko. Wayne is not with us yet, but he'll be there soon, I understood. So I think it's best to start up with our virtual tumor board. We thought of a few cases that would be really interesting because they are probably the most common tumor types. And we'd like to address them with three cases actually. In this webinar, we have a Q&A button, and you can see them at the bottom of your screen. And we would like to ask you to put your questions there, and Lorenzo and I will try to find those questions. It's also a possibility if you see a really good question in the Q&A, you can put a thumbs up button there, and if there are a lot of same people wanting to have the same question asked, then we'll definitely put them through to our expert panel. Furthermore, we have a few polls, so we'll be running a few polls on especially the management in these patients. So we would really appreciate it if you would join the polls, and we'll of course, again, ask our expert panelists to answer these questions. So I think it's probably best to start up with our first case. Starting that, I think with the first slide, this is a 71-year-old male with a medical history with a CVA, a sigmoid carcinoma, dysphagia and adenophagia, and an excellent performance status. Has on endoscopy a tumor from 34 until 43 centimeters with a junction 2 centimeters below that. It's a poorly differentiated adenocarcinoma, HER2 negative. This is the staging workup. So we do a EUS. Again, the same centimeters, no gastric involvement there. And we performed staging PET-CT, as you can see here. Clearly tumor uptake. And so in summary, this would be, next slide, a poorly differentiated adenocarcinoma, distal esophagus, no metastasis, HER2 negative, and a clinical stage of T2N1. Probably the first question for the panel would be maybe Simon, you could comment. Would you do any other diagnostics in this patient? Your microphone is muted, Simon.
Sorry, can you hear me now?
Yes.
No, that's probably what we do often. But having said that, this type of cancer, we don't really see it that often in Asia. This is a truly lower esophageal adenocarcinoma. As you know, in Asia, reflux and Barrett's esophagus and Barrett's cancer is still comparatively uncommon compared to sort of proper EGJ junction tumor. So this is pretty much a Western disease.
Okay, then maybe Mark Smithers, could you comment? You're on mute, Mark.
So
you're again on mute.
For this case, I wouldn't do any more. I think it's quite clear, the staging. I wouldn't see any value in endoscopic ultrasound. And some people might question the role of laparoscopy, but I wouldn't do that for a CVIT1 case. I would only consider that for CVIT2 or 3 type surgery, cancers.
Maybe you can ask Wayne, the use of endoscopic ultrasound and fine needle aspirate biopsy of all clinically positive lymph nodes. Would you do that, or is that something that you recommend, and why?
Okay, well, let me know if you can hear me, but we definitely recommend moving forward with EUS because we found that EUS is more sensitive for detecting lymph nodes in the mediastinum than imaging. So it changes our radiation field. So if you're planning on doing radiation, and if you find an upper mediastinal lymph node or a lymph node that's 4, 5, 6 centimeters above the tumor, knowing that information could change your fields. So we advocate for EUS.
How often does that happen, that it changes your field, Wayne?
That's a great question, Mark. I would say it's probably 10% or less, but it's not insignificant that during our tumor board, we talk about the PET scan or the CT scan showing no disease in the mediastinum, and the EUS guys pipe up and say, hey, we biopsied the lymph node up here and it was positive. So it's not frequent, but it happens here. Okay, thank you. So the next question would be, and I think it's a good time also to start the first poll. We're going to ask our panel, for example, John, what kind of therapy would you recommend in this patient?
I would recommend our standard here is we're doing a clinical trial, the Neoadjuvant trial, so the patient would be randomized. I have a position of equipoise with respect to flat versus cross in this exact context. But previously we were doing a cross regimen for this type of context. Okay, Wayne, what would you recommend in this patient? I'm not sure Wayne is still there, but maybe Mark, could you comment?
We would use cross on this patient, CVIT1. I'm aware of John's trial, and we're looking forward to seeing the outcomes from that, but we would use cross.
Okay, all right, guys. Yeah, I'm here. Wayne, what would you do? We use 50.4, so it would be chemoradiation with 50.4 based on our previous experience and some of the older studies before cross came out. Okay. Let me see, Lorenzo, what would you do?
We tend to use the neoadjuvant chemotherapy. We've been using docetaxel for approximately 15 years based on a local trial. We switched from DCF to FLOT due to since the FLOT4 trial was published due to less toxicity. But we would definitely use neoadjuvant chemotherapy for an adenocarcinoma. Maybe Yuko, Simon or Yuko, can you give us a Japanese perspective?
Yes, Yuko. As Simon mentioned, this type of adenocarcinoma on distal esophagus is very uncommon in Eastern Asia. We don't have any evidence and standard. And of course, upfront surgery is one of the options, but maybe we would do some neoadjuvant chemo, not chemoradiation. So option is 5-FU cisplatin or SOX. S1 and oxaliplatin is now under investigation for phase 2 trial for esophageal cancer. But so it's investigational and no evidence and no standard in Japan.
Simon, what about from in China, in Hong Kong?
I think just like what Yoko said, but like I said, this type of cancer is not very common, so we don't really have a proper protocol for this. We only had one image. This looks like readily resectable. So upfront surgical resection is definitely an option, but I guess most would probably go for neoadjuvant chemotherapy rather than chemoradiation in this particular case.
So the poll, our audience poll, it looks like I'm not sure if you guys can see it, but the vast 2/3 of the audience would start off with chemoradiation therapy. Half of those would consider salvage surgery if only if they had non-complete clinical response. And I think Wayne is there at the bottom. One person would choose definitive chemoradiation therapy, most likely from Houston.
Okay. Let's close this poll, and then we can go on to the next talk, because we already heard some discussion. Lorenzo using chemotherapy. We here in Amsterdam, we also use chemoradiotherapy in these patients and then surgery. We have asked John Reynolds to prepare just a few slides.
Okay.
And he's going to talk us through them in almost 1 minute.
Okay, well, I think the poll is right. And for this C2N1 type 1 case, multimodal therapy and chemotherapy are both good options based on published randomized and non-randomized comparative data. Importantly, just press the slide, best shown in the NeoRes trial, it would appear that survival for adenocarcinoma is not dependent on a PCR. Secondly, non-randomized comparisons from European and North America suggest that this equivalence is only obtained when en-bloc high-quality surgery is performed following chemotherapy, and that's important. Next slide. Current randomized trials are therefore very important. For this patient, Esophageal, which is FLOT versus CROSS, which has completed recruitment, and Neoadjuvant, which is CROSS versus FLOT or MAGIC, which will complete within a year or so, will help answer the question if one approach is superior. Also, they address the fundamental whether radiation therapy is required, as does indeed Top Gear, which would include type 2 and type 3 and gastric tumors, but not type 1. Next slide. So final slide. Finally, these are the high impact modern trials like CROSS and FLOT that have influenced or changed practice. In 2020, for this patient, next slide, we have no standard of care in my view. The current trials will give us randomized data on over 1,000 patients in 3 years or so, so we must wait and see if there's a winner. And we will still have to try and pick out what the right approach is for like CN3 cases or CT4A cases and so on. They may not be answered by it. Final point very briefly, just yesterday, a press release of the Checkmate 577 study of nivolumab versus placebo post-multimodal therapy and complete resection of AAG tumors reported that it had met its primary endpoint of disease-free survival. So this is tomorrow's world and some further food for thought. Thank you.
Okay, thank you, John. So yeah, this is what we did. This is the way we look at the patient, but also the way we talk about it in our MDT. So we like to discuss with our radiotherapy oncologist what the radiotherapy field looks like. I saw a question on the Q&A on the length of the radiation field. And if we have to worry about that, for example, with this length of a tumor, I think we're getting more experienced, more than in the CROSS trial. So and radiotherapy is getting more accurate. So we don't worry about that much. So after
you have a maximum length mark for radiation.
Actually, we don't have it. It was, of course, you know, in the CROSS trial, the maximum length of the tumor was 8 centimeters, with a maximum of 2 centimeters in the cardia. We tend to not use radiation fields that distend in the cardia very far, because we think that's not good for your gastric conduit. So in those patients, we would choose FLOT. So the next is what you see. We always use a PET scan to look at our post-neoadjuvant therapy situation. Still 11% of patients show metastasis then, so that's the reason we do that. And you can see a nice response in this patient.
Maybe because you need a little bit more systemic therapy to cover those patients, so they wouldn't get it. So we'll talk about that later.
That's a good discussion. And John just pointed that out, I think, Lorenzo. So the next slide, please, is, of course, the surgical procedure and approach.
This is our next audience poll. The surgical approaches that we're looking for answers are: what is your surgical approach, and if you do it open versus MIE? Mark?
Yeah, so I'd like to know from the panel, just starting with John, what kind of approach would you use with this patient?
Well, I must say I'm still doing open, en bloc, radical esophagectomy, Ivor Lewis in this stage, in this patient with a high intrathoracic anastomosis.
Okay. Wayne, what do you do?
I tend to do a hybrid Ivor Lewis, so that's what I'm liking so far.
And
but it's an en bloc operation really, so it's a very extensive lymph node dissection.
And abdominal phase laparoscopic?
Laparoscopic abdominal left thoracotomy for the chest.
Okay. Simon, what would you do?
I would do an MIE with the anastomosis in the neck.
Okay. Yuko, what's your strategy in this patient?
Just same as Simon's, and I would do extensive upper mediastinal lymph node dissection, like, even for distal adeno, and this is almost same as Simon's approach.
Okay, I think Mark, we also want to hear from you. What would you do?
I would do a 3-field dissection MIE. My standard operation has been a hybrid with a thoracoscopic chest and open abdomen, but we've moved to laparoscopic abdomen as well.
Okay, and 3 fields, you would also do a neck?
3 fields for this case, anastomosis in the neck.
Mm-hmm.
Okay, and why would you choose for a neck anastomosis and not an Ivor Lewis?
Well, it really relates to us when we first started doing this in 1995. We were scared of the anastomosis in the chest when we first started doing MIE, and our outcomes have been really very good. And so we would tend to use an MIE Ivor Lewis if the fundus had been irradiated, or if we felt we did not have enough stomach to be able to get to the neck. So that's still our standard operation for this sort of cancer, for a CVIT1.
Mark, do you consider this also oncological benefits, or just all this post-operative complication benefits?
I think that our data would suggest that oncologically we have the same outcomes. I think a leak in the neck is not quite as a problem as a leak in the chest. We're doing a lot more Ivor Lewis now, minimally invasively, because we've become more confident about the operation. And like everybody in the world that started doing MIE Ivor Lewis's, our leak rate was high-ish, and that's now controlled and much better.
Okay. So the audience polled, and they would consider, well, I would do an MIE with a left lateral enhanced anastomosis, but the audience had a slight preponderance, basically equal Ivor Lewis and 3-hole, and 75% MIE. But I think we all recognize that pretty much any operation that you do is acceptable for this, either open or MIE. So what do you do, Mark?
Yeah, so just showing you here that we did a thoracolaparoscopic Ivor Lewis with laparoscopic abdomen and thoracoscopic thorax with the not in this phase, but we make a very small mini thoracotomy to take out the conduit and to staple a circular stapled anastomosis. We do that end to side, and we try, if possible, to use a 29 millimeter circular stapler to do that.
Can I ask a question?
Yeah.
Of course you can.
It's about people's view on superior mediastinal dissection. I think even in Japanese data, with this proper lower esophageal third tumor, then there are significant metastases to the superior mediastinum, especially the right recurrent laryngeal nerve lymph node. So from the Western perspective, when you do this type of surgery, do you routinely do superior mediastinal dissection as well?
Yes, we do that actually in all Siewert 1 adenocarcinoma. So we do a right and left upper mediastinal dissection. And we were just discussing that before we started, but for that part, the prone position, I find it very helpful also to get into the superior mediastinum.
So I would say from us, so we don't do a routine supracarotid lymphadenectomy for distal third adenocarcinomas, but for mid squames, we tend to do a supracarotid lymphadenectomy and neck dissection. That's our perspective. I know in Japan, Yuko, what's your approach for distal third adeno? We treat it the same as a squame?
Yes, we have done some prospective study for the distribution of lymph node metastasis of EG junction tumor. The interesting thing is there is no difference between squamous and adeno. Just location or esophageal invasion is the most important factor to predict extent of lymph node metastasis. From this result, we cannot change the procedure between adeno and squamous, so that we do a very intensive, extensive lymph node dissection along the bilateral recurrent laryngeal nerve, even for this case.
It's Mark here. So I'm with you, Lorenzo. We don't do a superior mediastinal dissection, and in our series of nearly 800 cases, the patterns of care, the patterns of recurrence would not suggest that we should have been doing superior mediastinal dissection. There's a question there, and we certainly don't do 3-field, and we don't do neck dissection for this sort of case.
For another discussion, for our next tumor board, we'll talk about local regional recurrences. I think it's too much to talk about that right now because unfortunately I have had some along the left recurrent laryngeal nerve, but we're able to salvage them in certain manners. But we'll talk about that later on. So Mark, let's proceed with
the pathology in this patient was a YPT2N1 with 62 lymph nodes, 1 positive, and Mandar 3. So maybe we have time for some small question on this case, and I'd like to ask Wayne if you would use any adjuvant therapy in this patient, especially if it would have been a higher state in this case.
So because we use upfront chemoradiation, we are not doing adjuvant therapy. It's been a discussion that we have at our multidisciplinary board very consistently, especially when we have multiple lymph nodes positive. There are ongoing randomized trials with immune therapy for patients who have persistent mediastinal lymph nodes or abdominal lymph nodes. But I would say our typical response right now after chemoradiation, even with positive lymph nodes, is observation. Not that I'm happy about it, but that's what we're doing.
So Smithers, there's a recent, the checkpoint 577. It's not been published, but the results came out that adjuvant therapy in lymph node positive disease using immunotherapy may be a role. What's the approach in general for people who are lymph node positive after chemoradiation therapy in Australia?
So we would observe the patients. I think there's no data that adjuvant therapy after cross chemoradiation, that would make a difference. I think we'll be a little more informed when we see what happens with the chemoradiation versus chemo trials, because those patients are getting post-operative chemo. But right now, I don't see there's any evidence, and our patients are beaten up enough after their treatment and their esophagectomy, and I quite like the fact that they don't get beaten up anymore with chemo after, especially when there's no data to support it that's going to improve their survival.
John, do you have any input on this?
Yeah, no, I agree there's no data, but I don't agree that we should give up on YPN2 or N3 cases. They have systemic disease, they're going to fail, the median survival is poor, and it's very difficult to, just because we haven't designed the right studies and have that sort of data, to say we're not going to treat you with chemotherapy when they haven't really been treated with full regimen chemotherapy as a combination, as part of their combination cross regimen. So I'm very concerned by just leaving these patients and observing them. I think we should be a little bit more aggressive, although there's no data because it hasn't been studied in a very targeted way.
So one of the problems is, of course, that as Mark Smith has said, they're really beaten up. Lorenzo, can you comment, because you give them neoadjuvant chemotherapy? Could you give us an indication of the percentage of patients that can have their post-operative chemotherapy?
Well, I'll answer that a different way first. First, I'd say yes, it is difficult. Around 60% of them are able to continue all 6 cycles of chemo. Well, that's when we did our trial of 3 and 3. Now with FLOT, it's a little bit better tolerated. It's around 60, 65%. You need a motivated patient population for this. But I will say that patients who have N2, N3 disease, YP, N2, N3 disease after chemotherapy, particularly with a docetaxel-based regimen, those patients have a significant survival rate. We looked at our own YP N3 disease with greater than 7 lymph nodes positive, and we found that we have still a 35% 5-year survival in that extremely high-risk patient population. So I think the chemotherapy in that patient that you're giving up front addresses some of that systemic disease. And I think there's a question from the panelist about the role of PCR. Maybe, John, you can comment on this. What is the role of PCR in predicting long-term outcomes?
Well, PCR is if, if somebody has a PCR for any of these tumors, they have about a 70% cure rate, which is fantastic. But I think the thing about adenocarcinoma, the case we're discussing, is the PCR is not everything. And that's why the chemo and chemoradiation studies and outcomes are equivalent. But I think the big area is the N2, N3s post chemoradiation, because they have not had your docetaxel or other regimens like FOLFOX that might help them, because their median survival after chemoradiation with heavily node positive disease is terrible. It's very poor.
Honestly,
sorry, go ahead, Simon.
John, I think if these guys have undergone chemoradiation and then they still have N3 disease, probably they've had it anyway. So I'm not sure. I see your points about because they have so many lymph nodes, you should add something. But again, like you say, there's no data out there that we should add anything. So it's a difficult decision, I think, but there's no clear answer.